I feel like we should spend a little bit more time on this baroreceptor reflex because it was kind of short on the previous part. So the baroreceptor reflex works both ways, whether you have an increase or a decrease in blood pressure. In fact, it works probably a lot better when you have a decrease in blood pressure. A sudden decrease in blood pressure is perceived by your body as immediately life-threatening, because the job of the cardiovascular system is to bring blood and nutrients up to the brain as a vital organ, and it can only do that when there's sufficient pressure. So if there's a sudden drop in blood pressure, you know what it's like when you get up out of bed too fast. If your blood pressure is already kind of low, then you feel dizzy. If you're changing your body position all of a sudden, because the baroreceptor reflex, it takes a little bit of time to compensate for that, for you getting up too fast. So your body is really concerned when the blood pressure is low. When the blood pressure is high, your body doesn't really care that much. But that's why we have so many people with high blood pressure, as opposed to, if you have low blood pressure, you either pass out or you're going to do something about it. So high blood pressure is known as the silent killer, because so many people have it and there are no symptoms, and your body isn't really that worried about it because it's a long-term thing. It doesn't kill you now, so your body figures, it will go away eventually. But it's wear and tear on the heart and on your cardiovascular system. That's the big long-term problem with high blood pressure. Nevertheless, the baroreceptor reflex, as stated here, it's showing you how it compensates for an increase in blood pressure. So if for some reason you have an increase in blood pressure, and your body does have a mechanism to compensate for that. So the goal would be to lower your blood pressure. And I do have to tell you, it doesn't work that well, but, I wish they would have done a sudden drop in blood pressure. Then I could have explained this a little bit better, I think. But here we are. So we have an increase in blood pressure. The goal would be to decrease the blood pressure. So we need the parasympathetic side to kick in more. So we're going to increase the parasympathetic side, decrease the sympathetic output. And basically you will drop some acetylcholine from the parasympathetic side on the SA node to slow down the heart rate. You want to decrease the cardiac output. The whole goal would be to decrease blood pressure. And on the sympathetic side, you want to down-regulate the sympathetic side, because your blood pressure is too high. You want to lower it, so you don't need any sympathetic inputs. You want to make sure that you decrease all of that sympathetic side. What you can do on the sympathetic side would be try to see if you can get some vasodilation that will assist with the reduction in pressure. So you want to lower the peripheral resistance, and then your goal again would be to lower the blood pressure. Next up here, there is a series of slides that sort of give you an example of what happens when the resistance in a particular blood vessel, the resistance increases. That means the blood vessel diameter decreases. And so here they have the example that arteriole A, which is this one right here, it has increased resistance. That means we're putting here, we're closing this up or narrowing it down so that there's not much, if any, blood flow going through vessel A. And that has an immediate backup effect onto the vessels that are immediately preceding here. So that will be, in this case, I guess this looks like the aorta. So we're going to have an increase in total peripheral resistance, and that will mean that we have an increased mean arterial pressure. It makes sense, because you want to push the same amount of blood now through 3 vessels instead of 4 that you used to have. So now you have more resistance. That means you need to increase the pressure in order to get all that stuff through these 3 remaining vessels. Once the mean arterial pressure has increased, your baroreceptors will kick in with the mechanism that we just talked about. So you want to increase your parasympathetic side, decrease any sympathetic input, and the baroreceptor reflex will then make sure that you're going to have a decreased cardiac output by lowering the heart rate and decreasing the resistance. So you want to try to open up some blood vessels so that your mean arterial pressure will be restored to normal. So that's just an example of the baroreceptor in action. And the following slides, you can take a look at this in steps. Again, we're going to narrow down blood vessel A, or close it up. That increases the total peripheral resistance. And we're going to compensate for that with the baroreceptor reflex, which will kick in and restore the mean arterial pressure to a normal level that it should be. Now let's take a look at what happens in capillaries. Of course, you want to have exchange of materials, and depending on the size of the materials that you want to exchange, it's going to be easier or a little bit more difficult. So first of all, you want to make sure that the capillary walls are really, really thin. Basically, capillaries, they have the thinnest walls. They have a single layer of endothelium, and these cells are really flat to make sure that the distance that something has to be transported across or diffuses across is minimal. They are supported by a basal lamina, and well, as we said earlier, capillaries are either leaky, those are the standard capillaries, or they're leakier when they have little pores or windows, or they are leakiest if they have basically large gaps. And some tissues, like in the bone marrow and the liver and spleen, they have these sinusoidal capillaries. They have just very large gaps to make sure that you can have maximum exchange. So here will be a standard leaky capillary. You can see how these cells, these endothelial cells here, they have a large surface area, but they're really, really thin. And that's a good thing because you want to make sure that the diffusion distance is minimal. Also, the junctions between the cells, they have these gaps, and these gaps can be wider or more narrow, but you can transport stuff, we'll get stuff across using these gaps right here. The other thing you can do is you can package something up in a vesicle and then do transcytosis. So basically you're packaging these little purple dots into a vesicle and then moving the vesicle across, and then across the capillary endothelium. Here's an example of a fenestrated capillary. So that would be the leakier ones. They're not the leakiest ones, but they're leakier than the standard capillary. And they have large pores or windows. So it would be these fenestrated pores, and they make it easier to get stuff across. So here will be a fenestrated pores, and then it makes it easier to get stuff across here. They still can do the transcytosis as well, moving stuff across the capillary endothelium. And then some of these vesicles, they can also fuse to create a sort of a temporary channel. So they're here, you're fusing these two guys together, and then you have a little channel, a little pathway that you can use to move stuff across. Moving on to the velocity of blood flow, let's take a look at this here. The speed at which blood travels through your cardiovascular system, well, the highest speed will be reached when your blood is leaving the left ventricle and it's going into the aorta. So that's a single vessel right here. It's large, but it's only one. So the total cross-sectional area of that one vessel is very small. And you will have maximum speed and maximum velocity of blood flow in that first vessel. And then as you're going into arteries and arterioles, your speed at which the blood is traveling is dropping very quickly. But on the other hand, the total cross-sectional area of all the blood vessels collectively that the blood is traveling through is going to increase. It's going to reach its peak with the capillaries. Now, a capillary, one by itself, of course, is hair thin, but you take all of them together, collectively, you're going to have the largest cross-sectional area out of any type of blood vessel. So in the capillaries, you have maximum total cross-sectional area, so largest total amount of area that the blood is flowing through, and therefore the speed will be reduced, which is a good thing because you don't want to be going full force into a capillary bed. Remember, you have to do exchange, so you gotta give it a little time. Think of it as picturing like I don't know, a really wide riverbed where the water is flowing nice and slow. If you narrow it down into a channel, then if you want to process the same amount of water, things will speed up, and then you have rapids and you have a lot of turbulence as well. So anyway, in the capillary beds, we have not much speed, not much velocity, but we have a very high collective cross-sectional area. And then as we're coming out on the venous side, the flow will never be very large because on the venous side you just don't have another pump, but it's actually going up considerably. But here the cross-sectional area will go down as you have fewer and fewer vessels, and at the end in the vena cava you only have one vessel. Back we're at a minimal cross-sectional area because it's just one vessel. Now coming back to the capillary exchange issue. So we do want, well, first of all, we're slowing down blood flow in the capillary beds, and now we want exchange of materials. And depending on what that material is and its size, you're going to have to do different methods. If you try, if something is small, dissolved solutes and gases, they just move by diffusion. So there you just need to make sure that your diffusion distance is nice and small, and then things will just simply go down their concentration gradient. Larger solutes, sometimes proteins, they need to move by vesicular transport. And so we talked about this, the mechanism of transcytosis a little while ago. And so here another slide that summarizes the capillary exchange. So you're going to have bulk flow, that will be mass movement of stuff going down concentration gradients. Then we have absorption of fluids. We have some net absorption going on. We'll talk about the whole issue of colloid osmotic pressure in a little bit. But in the beginning of a capillary bed, you have a pretty large outward force, and that's called filtration pressure. So that one is on the arterial side. We have net filtration, and on the venous end, we're going to have some net reabsorption of these fluids that we've lost, and we're using mostly the mechanism of the colloid osmotic pressure. And again, we'll talk about this in a little bit. I mentioned it to you already when we did the blood labs, how important the colloid osmotic pressure is. So hopefully you remember that term. But here's basically sort of the general principle. Your blood is coming in through an arterial. We're going into a capillary bed, and now in the beginning of a capillary bed, you have a pretty large outward force, and that would be net filtration. So an outward force, stuff is leaving. And then a lot of water will be leaving too. So at the end of a capillary bed, you're going to have a lot of net reabsorption, especially of these fluids, because we have large proteins that stayed back, and they're creating this colloid osmotic pressure that sucks the fluids back into here by osmosis. Now, unfortunately, net filtration is not equal to net absorption. So you always have some more filtration than reabsorption. And therefore, we need these lymphatic vessels that sort of pick up the rest of what wasn't able to be reabsorbed into your cardiovascular system. So the lymphatic vessels are supposed to be picking up whatever was left over and then returning it to the venous side of the circulation eventually. So here's another diagram showing exactly the same thing, sort of these fluid compartments that we have and how they're exchanging fluids constantly. You just have to keep your balance, and we'll pick this particular image. We'll come back when we do the kidneys and also in the gastrointestinal tract. But when it comes to fluid balance, you really want to maintain equal input versus output. So you need to have input equal output. Okay. Let's put some numbers to this here on the net filtration pressure. So basically, that's the hydrostatic pressure of the blood capillaries minus the hydrostatic pressure in the interstitial fluid. On the arterial side, you have a blood hydrostatic pressure of 37 millimeters of the mercury, versus on the venous side, you only have 17 millimeters of the mercury. So you have a significant discrepancy here between the arterial net filtration pressure and the hydrostatic pressure at the end of a capillary bed, so on the venous side. And that has consequences. And in order to minimize this discrepancy and recapture the fluids that you have lost, you need to have something called colloid osmotic pressure. It's very important. It's the plasma proteins that are in your blood. They are too large to leave, and you need them. You need them in order to reabsorb these fluids that have been lost in a capillary bed. And here are some numbers for you again. The plasma osmotic pressure is 25 millimeters of the mercury versus the interstitial between the cells. Osmotic pressure is 0. And so there you can use this force to reabsorb